So getting to the topic at hand, my name is Kristy. I'm the Nursing Operations Manager for a Trauma Burn ICU and Trauma Burn Step-Down in Orlando. And this here is Victor, and he is a staff nurse on my Trauma Burn Step-Down unit, and he is also my unit practice chair. That's it. We have no relevant financial disclosures. So the objectives of this presentation is for us to be able to analyze the number and types of calls made to burn physicians at night on a step-down unit and discuss the impact of providing education to nursing to assist in prioritizing urgency of calls, and then examining the benefits of decreased call volume on both physician and nursing teams. So before I go over the overview, I wanted to give you a little backstory because it started when a physician who was extremely frustrated came to me as the nursing operations manager and said, I'm really, really frustrated at the immense amount of calls that my physicians are getting at night, especially when the majority of them could be handled on daylight shift. And so, of course, as the nursing operations manager, I take a lot of pride in both our physician and nurse collaboration, and so I made it my duty to see what the problem was and to ask my unit practice counsel to figure out what was going on. It is linked in the literature that call volume directly impacts burnout for physicians and residents. And I just know from being an operations manager that calling physicians, especially at night, is really stressful on nursing as well, especially depending on their level of experience. So what we looked at as far as burnout factors was physicians tend to receive an unmanageable call volume at night, mostly because of limited resources. Nurses get frustrated because they don't get return call back, or when they get a return call back, sometimes it's from a very frustrated physician. And we know that the factors that influence increased call volume is the level of experience of both physicians and nurses, as well as the workload. So I took this problem and I said, Victor, I need you. I need you to track and look at this problem and see what we can do. And so he's going to tell you what the team came up with.
So Kristy provided the need. We needed to figure out why were we calling so much and what were we calling for. We set out with the Nurse Practice Council, and I just want to set out thank you for Natalie Cantillo, who was part of the Nurse Practice Council. Herself and another member, we set out to get a log and actually catalog the data. The reasons that we were calling, the time of call, those are the two that we're going to camp out on the particular data you're going to see in a bit. But the physician teams, which included a variety, the method of we were calling, and the responses from them as well, and the number of times we had a call, whether to escalate it if that was necessary or not. So with that information and that baseline data, we were able then to provide it to Kristy, who was then able to provide it to the surgical resident head of the department. And we'll go on to what she did with that information.
All right, so with the data that we collected, we were able to identify 3 areas that we could impact. And one was clarification on urgent versus non-urgent, which seems pretty simple, but when you're a nurse, we talked about this together, when you're a nurse, everything feels so important. And so you really wanted to be able to call for anything at night to make sure that your patient's getting the best care. So that was our first step. And then the second one was making sure that we had a chain of command policy, but it's lengthy, and so we wanted something easy access, so we made a chain of command that was easy to reference for the nurses. And then lastly, developing a collaborative, purposeful rounding between the physician and nurses so that they could identify hot spots early in the night, and so that they don't get as many calls over the shift.
So did it work or not? As you can see in red, we have the pre-intervention, and in blue is the post-intervention. We saw a drop of 71% in calls overall amongst all the teams that we were calling at night. Mind you, this is at night. This isn't just daytime. This is everything at night. I, myself, was a new nurse when we started this. I was probably a year into it. So for me to experience the challenge of having to drop my calls, all of us, for those of us that are nurses, everything's important. Everything's urgent when you first start. And physicians, well, not everything's important, not everything's urgent. So as we can see, the interventions that we set out to highlight, educating the nurses, urgent versus non-urgent, having to have a good chain of command outline as to why we were calling and as to how much time the physicians had to call back, and then collaborating with those physicians and having them either round or just be proactive in general and have things done before we needed to call them. It made a difference. You can see here, pre-intervention, post-intervention, 71% drop overall. In addition, we took the data as to why we were calling, because that needed to be addressed when we're doing these urgent versus non-urgent needs. And what we did here was, these are 20 categories. There was a few more before, but of these 20 categories, those that are from cardiac concerns and to your right, those are all urgent needs, and I'll explain one in particular that might seem off. And then everything to the left of cardiac concerns are non-urgent needs. So on the far right, you see order requests, and it's in red because as nurses and as doctors, you know that nurses can't act. So anything that we were calling for, we wanted an order to do so, to act. And everything on the left, well, those are the urgent needs that we thought were there. Post-intervention, everything dropped. Even the request for orders so that we could act. And all those needs that were on the left at one point that seemed urgent, we realized they weren't urgent. And we were able to relax and care for our patients more effectively because now we were able to focus on the important things, such as vital sign changes, order for clarification. And one thing that comes up, and I have to explain, diet orders. We are a surgical floor, or not surgical floor, we care for surgical patients. So sometimes we have orders that have to be clarified pre-op. We kind of caught it in time. Hey, doc, we need an MPO, or hey, doc, we need to put them on D5 because their sugars are dropping. So these are the diet orders that are being reflected there. And they are urgent because sugars dropping is urgent. As a result, in summary, we saw specifically for the burn care team drop in calls by 55%. And we saw the concerns in general drop from 10 down to 5. In addition, our nurses indicated that they felt that their knowledge had improved significantly as to what was urgent versus non-urgent. And they also reported that the interaction between nurses and physicians, that interaction improved significantly, as did their communication.
I just wanted to share that when I came back to the director of surgical residence, he was so very impressed. And of course, you can see the data that we decreased the call volume by a lot, but he actually felt it, and he said his residents felt it as well, and that they felt more comfortable calling the unit knowing that the concern was going to be urgent versus for something that may or may not be as important or could be handled on the daylight shift. And then from a nursing impact, our biggest thing that we had to worry about is making sure that we hit everybody that we onboard. As we have nurses that leave the profession or go up or go to become nurse practitioners or wherever that they go after the unit, how are we making sure that when we onboard either new nurses or even seasoned nurses that join our team, what's the difference between urgent and non-urgent? What's the chain of command? And how do we make sure we're communicating effectively with our physicians? So it worked out really well, and the physicians were very happy. And I just want to say, we had to present this. We have a quality triad that we do every month, and we presented this on behalf of our unit, and now other units are trying to implement the same process because it happens all over the hospital, and it happens wherever you go, and specifically on units where they're heavy with GNs and new nurses. So these are our references. Any questions? All right, so we have no relative financial disclosures. And our objectives are, we're hoping that after this presentation, you'll be able to summarize steps to take to change a culture from being reactive to proactive, and that you can apply one idea that can be used personally for yourself or on your unit to mitigate compassion fatigue. So, same with the last one. The background here is that, most of you guys know that nobody has an elective burn surgery most of the time. It usually comes from some type of traumatic incident, and usually there's a lot of complex psychosocial things that are happening that the patients and families are going through, but the nurses and the physicians are going on that journey with them. And so it causes a lot of compassion fatigue. And it's just the nature of our environment. But what happens is that we have an incident that happens, and we might have a reactive approach, and we might address it, but we don't ever really come back down to baseline. And then another incident happens, and then we don't really come back to baseline to the point where we never really fully recover. And that's when nurses usually decide to either leave the profession or go on and get an advanced degree. And the hardest part is that our patients don't stop coming. They keep coming, and there's not a lot of time for nurses and physicians to kind of reflect on what they went through and to address anything that's happening to them.
Okay, so our specific aim in this was to explore more proactive methods to support our team's emotional wellness and specifically resilience, because we wanted to reduce the compassion fatigue and the burnout. And we'd been pretty good at being reactive, but we wanted to get to be a little bit more proactive. For this, I used Maslach's Burnout Inventory, which we'll discuss a little bit more. And then our drivers were nurturing the emotional wellness of team members in a variety of different ways, so a layered approach versus a one and stop. We wanted to change the culture to be mindful about supporting each other, and we wanted to focus on being proactive, along with continuing to use those reactive things that we'd been doing for quite some time. And doing all of this would strengthen a healthy work environment. So was it the green one? Excuse me. So our design was doing the PDSA. We collaborated nursing leadership, spiritual care. Spiritual care was one of our reactive ones. So this is something that we were very used to using, and if they were aware of a situation, very frequently they would do something they called high tea, where they would, create a beautiful room somewhere where there was, cakes and tea and whatever. You could kind of go in and relax for a minute. And that was awesome, and it continues to be awesome, but we wanted to add another layer. And so in this case, we went to employee wellness. There were coaches that had recently been hired into the organization, and they came in first as physician coaches, and we kind of hijacked them a little bit and said, we need this as well. And so bringing them onto this team was really important. Now, as far as the Maslach Burnout Inventory, this is a valid and reliable tool, and it's an introspective psychological inventory. It's got 22 items on it, and it basically measures occupational burnout. And the subscales on this are emotional exhaustion, depersonalization, personal accomplishments, cynicism, and professional efficacy. So this was a tool that we used to assess the team. We did this twice, and there was 8 months in between the 2 times that we did it.
So we had a particular incident that happened on the unit in which there was high emotional stress on the unit, and actually one of our physicians called one of our wellness coaches, and we reacted in the moment. They came to the unit, they talked with the nurses and the physicians to help get them through that specific incident. But what had happened was that it triggered us to say, are we effectively proactively addressing their emotional needs? And so I wanted to know what the team thought. And so we set up a brainstorming session, and we included, of course, leadership, and then the chaplain services who had been our partners all along. We added the wellness coaches, and then, of course, bedside caregivers. And we asked them a few questions. We said, what triggers your burnout? These were the things we wanted to know. And then what helps you fill your cup? And that means what makes you come back to work? How do you decompress when you go home? What kind of things make you want to come back and still be a nurse? And then what does proactive emotional support look like? And that was hard. It was a hard question to ask people, because what does it look like if you were to really think about it in your head? And we came up with some pretty cool ideas when we all put our heads together. So these were some of the interventions that we came up with. The wellness coach already coming up PRN. They had a psychological they were counselors as their background, so they could come up whenever we wanted them to come up. But we thought it'd be nice if they could come to the unit once a month, sit on the unit during day shift and night shift for an hour. Anybody that's on the team that has a moment, they can go in and talk to them and kind of offload or talk about something that has nothing to do with leadership, doesn't have anything to do with their peers. They could just go and talk to them. So we did that. And then, of course, they were available as needed. We started a bingo board, which I'm going to show you on the next slide. We did a What Matters Most and a Twitter board, and I'll show you that. And then a psychological well-being, which was created by our wellness coaches, and I'll show you that as well. And then, of course, we use huddles, which is our shift-to-shift safety debriefings in the mornings and at night. And then we also have Gembas, which is twice a week, little meetings that we talk about safety issues on the unit and go over our outcomes. And then summits are our staff meetings, making sure that we have things there that also address emotional wellness. And then last but not least, quarterly planned outings. This is pretty common among nursing units. This is something we like to do to kind of decompress, get to know each other outside of work so that we work better when we're at work. And I'm going to show you some pictures from that. So this is our bingo board. And if you look at, I don't know if you can see it in the back, but each letter represents some form of your emotional wellness. So for example, B is physical, I is emotional, N is psychological, G is spiritual, and O is behavioral. And this board is actually right on the middle of our unit, accessible for anybody that wants to walk by and see. And the goal is that every nurse should bingo every week. And we use it as a talking tool. I know that at the end of huddles, we might say, hey, how have you bingoed this week? And there's all kinds of suggestions under every single letter that give you ideas for how you can maintain your emotional wellness under all of these categories. And this was created by our wellness coaches. The What Matters Most in the Twitter board, this is actually located in the staff locker room. So when they go to get their bags and they're getting ready to leave from their shift, we took a staff meeting to hand out index cards, and all they had to do was write on the index card what matters to them most outside of work. And then we gathered them all up and we made a collage, and so when they leave at the end of their shift and they walk out the door, they can walk right by that board that says what matters to me, and they can look and see, like, oh, it's my family, oh, it's my dog, it's pizza, somebody said that. That's important to somebody. So, and then the ICU Twitter, it hasn't really taken off as much, but we had a bunch of Post-it notes listed there, and it was supposed to be a way you could kind of send somebody a thank you, like, you got me through my shift today, and then they could take it on their way out the door, put it in their car, and be like, somebody appreciated me last night, so that they can appreciate the work that they do. And then this is the psychological well-being thermometer. This, again, was created by our wellness coaches, and it lists kind of where you're at from a red, yellow, and green wellness perspective, and it gives you kind of the signs and symptoms in each of those areas. At the bottom, it has our 2 wellness coaches, and next to it has their QR code that has their contact information. These are listed up on the unit for anybody to look at, and our wellness coaches have made it very clear that they can call them at any time. And so this was just another way for them to have access at any time to somebody to talk to that isn't involved with leadership, isn't necessarily involved with the unit. And then our Gembas in the morning, or our huddles, this was us celebrating a nurse that's been at the bedside for 25 years. You don't see a lot of that anymore. And so we made sure that he felt recognized and appreciated for all the hard work that he does. And then, I know this is a lot, but these are all the different outings that we do. I originally started with assigning my assistant nurse managers to each quarter. They had to create an outing for both units, because I wanted them to be together. And so a lot of it has to do with healthy stuff. So like running, we have a lot of different runs, a heart walk, and Great to Donate. But there's a couple different things. We did an 80s bowling night, we did a Halloween party, Christmas party, but these are just other ways for people to get together and know each other a little bit more outside of work so that they can work together better at work. And it's been very successful. So Shirley's going to share the outcomes.
So the pre-intervention, our N size was 40, and at 8 months it was 23. And we did this at the summit. So those numbers are variable, and that's why you've got what you've got. You also have individuals that maybe had just come on board and such. So obviously this isn't research qualified, it's just, as I said before, a PDSA. So what we found was, although there was no statistical significance was found in terms of subscales, we did see that burnout appeared less at 8 months than it did at the beginning, so that was reassuring. And the relationship between depersonalization and emotional exhaustion was identified. And that's interesting because I don't know what you guys are used to seeing, but individuals that I work with, and myself included, we tend to compartmentalize. So when we're under stress or we're in a situation, we've got to put it in a little box in our brain, and we've got to put the lid on it, and we've got to keep going. That takes a lot of energy, obviously, to keep that lid on. And so what happens is you kind of get exhausted, and that's when we're talking about this burnout. And going along with that, individuals that were at the brink of breaking on shift were very resistant to take the opportunity to go and talk to the coach. So if she or he were present for that 1 hour of scheduled time, they were very reluctant to do that because they were afraid of, if I open that lid, I'm going to break down and I'm not going to be able to finish my shift. So that was one of the reasons that wasn't as effective. And so calling those people PRN often worked much better. So if I was on shift and I could see that somebody was really needing help, I'd say, hey, how about I take your assignment and Mary or whoever can come up and will you go into my office and spend some time? And that worked a lot more because then they just knew that their patient was cared for, I was available to do that, and they could stay in there for as long as they needed. So that was an interesting point. Also, we found that nurses who did see the wellness coach had lower burnout scores, but their emotional exhaustion remained high. So there was some impact, obviously, of having these things set up the way we did. And then what worked was increasing the awareness, the ongoing discussions, and the continual support. And so when we do huddle in the morning, it's usually just 3 to 5 minutes of just kind of talking about the unit in general, what's expected, what might be our hot spots. And so now we can, let's say there's an organ donor that we know is going to go on our shift, and we do this walk of honor, and it's very emotional. So everybody kind of stops what they're doing. They run over to whatever side of the hallway, and we line the hallway. And this patient will usually come out of the room. A family member might have a statement they want to make that'll just bring you to tears, right? It's just really hard. And so we think about that ahead of time. Hey, this is going to happen. So let's make sure we support each other. Let's make sure we take 30 seconds before we go running back to our patients and doing whatever. And so this is that increased awareness that we've talked about. And we're hoping that this continues to enhance our culture so that obviously, maybe the charge nurses are the ones that start to demonstrate this, but as we demonstrate this behavior, hopefully other nurses will take it upon themselves to help. Like if you do a DCD, that's death after cardiac, that nurse then comes back to the unit, and let's remember to accept that nurse back into the unit and sit and have a moment, because what they just did was really difficult too. So let's recognize that versus just, looking the other way. So lessons learned. The scheduled sessions were not fully utilized. The impromptu sessions seemed to be a little bit more helpful, and that the staff, once they experienced it and felt that relief, which many of them did, then they kind of understood what those sessions were about, and that they're completely confidential. There's nothing, they don't leave that unit or that meeting. And oftentimes I've invited the coach up with an individual, maybe we're both struggling with something, and just bringing that coach into the office and sitting and talking about it, it just gives you the ability to have a new perspective. You kind of twist that in your brain a little bit, and then your anxiety can diminish. So that's been helpful. I think that is it, but the one thing I want, next steps. As you all know, we work on something, we're really passionate about it, and there's so many other things that come down the river that knock you off, whatever the next, maybe it's joint commissions coming, whatever the case is. So it's really difficult to keep this in the forefront, but we want to continue to work with our wellness coaches on these creative approaches, and we continue to discuss self-care. It could be in 30-second moments on shift. It might be in a coaching session when you're doing evaluations or something. So always demonstrating self-care. And we as leaders have to make sure that we do that as well, because if we don't eat lunch, if we don't pee, if we don't do all these things, then nobody else is gonna. So we have to really make sure that we do this. So we're modeling the behavior. We're really pretty emphatic about taking uninterrupted breaks. And if I'm in the break room and somebody comes in to get somebody, I usually just give them a little look, and they usually back right out of the door, so that nurses can have their uninterrupted break. And then just teaching or modeling to, especially the newer nurses, what can they let go of? Nurses tend to hang on to things that they don't need to hang on to, or worry about things that they can't necessarily make a change for. So that's important. And then the best thing about all of this is what happened with the bingo board. And so all of a sudden, these Post-it notes started showing up on the bingo board. And I don't know if you can see them, but basically people were putting what they personally did under whatever those things are. It might be, kiss a dog, do yoga on the beach, binge something on Netflix while eating a pizza. And so that really showed me that we had kind of made an impact, and it was starting to touch people, and they were really thinking about it. That's it. Questions?
All right. Thank you guys for coming back. Sorry for the interruption. My name is Allison Cook, and I would like to thank the program committee for the privilege of the podium to discuss this important work. I have no relevant disclosures. My interest in education in burn care stems from my general surgery residency at Parkland Hospital, which was one of my first encounters with true suffering. Palliative care is not just for patients at the end of their life, but for patients going through serious illness or injury, and serves as a response to reduce suffering and improve quality of life. This quote from surgical palliative care pioneer Jeffrey Dunn highlights burn care as the paradigm for surgical palliative care and encompasses the impetus for this particular project. Burn care has taught us that the first step towards salvaging a patient involves attending to pain control, but the threat of physical mortality is only part of the existential threat resulting from devastating injury, because we also exist in social and spiritual contexts. Nowhere else in the practice of surgery is it so obvious as in burn care that existential salvation for patient and caregivers alike begins with a response to suffering. First, we must respond to the suffering. How are we doing that? Are we doing all that we can? What can we do better? These were the questions. A literature search of palliative care in burns yields few results. In light of this, and with the knowledge that the multidisciplinary burn team structure closely aligns with the core pillars of palliative care, we elected to structure our systematic review around the 8 domains of quality palliative care as outlined by the National Coalition for Hospice and Palliative Care consensus guidelines. We took keywords from each of these 8 domains, as well as keywords relevant to burn care, and searched 5 databases for interventions related to these. Our PCOTS question was, among adults with burn injury, do interventions targeting the 8 domains of quality palliative care, as compared to no targeting of these domains, improve patient and family outcomes and healthcare utilization after burn injury in any setting? Our inclusion criteria were adults greater than 18 years of age with burn injury who underwent an intervention addressing at least one of the 8 domains of quality palliative care. We excluded single case reports, case series, gray literature, including abstracts, non-peer-reviewed publications, narrative reviews, and articles with no original data reported. Our initial search yielded 7,532 unique abstracts, which were then dual screened by 2 members of our team for relevance. 238 full-text articles were each analyzed by 2 team members as well. Of note, Domain 2, representing physical aspects of care, yielded an overwhelming majority of papers, with 75 found. These represented pharmacologic and non-pharmacologic interventions. We elected to exclude these papers from this review as the sheer number warrants its own systematic review. The remaining 7 domains were represented by 13 articles, which were evaluated with data extracted and compiled in tabular form and summarized in a qualitative synthesis. Due to varied study design and outcome measures, a meta-analysis was not possible. When able, articles were evaluated for quality using the Cochrane Review of Bias for randomized control trials and the Newcastle-Ottawa Quality Assessment Scale for non-randomized control trials. The included studies were published between 1989 and 2018 and represent 2,472 burn patients, which is a very small number considering 500,000 patients are seen for burn care yearly, with the number of included patients in each study ranging from 22 to 808. The studies represent 5 different countries, with 8 of the studies originating in the United States. 6 of the 13 studies were retrospective cohort studies, 1 was a prospective cohort, 1 a retrospective cross-sectional study, and 5 are randomized control trials. The studies represent all settings of patient care, with 6 studies focusing on inpatient interventions, 3 on outpatient interventions, 3 on peri-discharge intervention, and 1 study included both inpatient and outpatient setting. 4 domains were represented by included articles, with cultural aspects of care, ethical aspects of care, and spiritual aspects of care not represented at all. Domain 1, structure and processes of care, held 3 articles, each evaluating interventions in the peri-discharge setting. Domain 3, psychological aspects of care, was represented by 3 articles as well: a self-care program, analysis of inpatient psychiatric consult evaluation, and cognitive behavioral group therapy. 2 articles assessed peer interventions in the social domain, and 4 articles discussed care for the patient at the end of life, particularly protocols surrounding determination of futility and decision-making around transitioning to comfort care. My apologies for the busy slide. Here's a list of our included studies. Our full tabular summary is included in our published manuscript, now available online. 3 of the 8 domains of palliative care were not represented by any interventional studies. As noted previously, a significant majority of existing studies focus on interventions addressing physical aspects of care and are not included here. Only 13 studies encompass the remaining 4 domains of quality palliative care, and these studies were predominantly small, single center, and of moderate to poor quality with high potential for bias. It is important to highlight that the included studies varied widely with regards to structure, terminology, and assessment of outcomes. 6 studies did utilize quality of life as an outcome measure. However, each employed varying assessment scales which precluded comparison of impact. 4 studies reported exploratory outcomes around end-of-life decision-making in burn-injured patients, and the remaining 3 utilized various outcomes, including health utilization, utilization of a dedicated staff member, in this case a psychiatrist, and as well as one study, the outcome was patient-reported usefulness of the intervention. Clinical implications of study findings include that significant literature gaps exist concerning both the palliative care needs of burn patients and ways that primary palliative care from burn multidisciplinary teams, as well as palliative care specialists, could improve burn patient care. Evidence from the included studies supports that peer support, group therapy, and peri-discharge education improve quality of life in burn patients. Protocols for decision-making and goals of care at the end of the life are feasible and improve end-of-life processes, including attention to symptoms when implemented. While burn research has historically focused on improvements in mortality and morbidity, outcome priorities are increasingly shifting towards function and health-related quality of life. Indeed, the large body of burn literature on physical symptoms could be interpreted as attempts to address the most outward signs of suffering. Yet, though vitally important to the care of burn patients, focusing research interventions primarily on mortality and physical symptoms negates that burn patients suffer from not only pain, but also threats to their wholeness and personhood, which impact their lifestyle, social life, and psyche and spiritual life as well. Our study highlights many opportunities for further research, including studying and incorporating all 8 palliative care domains into the care of burn patients, as well as their family members, and as the talk before me included, team members and nurses who take care of these patients. Developing a common language for describing palliative care interventions in this population, as well as reporting consistent outcomes as a means of comparing studies and providing comprehensive high-quality care to burn patients. Several limitations to this systematic review should be noted. As mentioned, due to the large body of interventional studies on physical aspects of care, these studies merit their own systematic review and are not included in this review. A review of this literature is needed and is a priority of our group. It should also be noted that burn units in the United States and abroad often treat both adults and children, and as our criteria excluded children, we may have missed studies that incorporated both adult and pediatric participants. Lastly, as the language used to describe palliative care practices in the burn literature is often ambiguous, we utilize broad search terms for each of the 8 domains of quality palliative care to capture relevant studies. Despite these efforts, related studies could still have been missed in our search. I would like to thank the other members of my team who represent UCSF, Yale, and Stanford, as well as the AHPM Research Committee Writing Group for making this possible. I would like to thank all of the burn patients that have shaped my career in education and thank them for allowing us to care for them and inspire us to do better every day. I'll be happy to answer any questions.
I'd like to thank the association for allowing me to present and my analysis on enteral nutrition initiation during periods of vasopressor requirements and elevated lactate levels. I have no disclosures. The standard Army disclaimer applies. We all know that nutrition is a core component of critical care in the burn patient. Current recommendations for initiating enteral nutrition are a little confusing, though. The Society for Critical Care Medicine recommends initiating enteral nutrition within 4 to 6 hours of injury, which I found difficult at times when the patient's not even here yet. They, at the same time, say that you should wait till the patient is hemodynamically stable for all critically ill patients. So those two things don't align. So that makes a lot of confusion. Other papers say to postpone enteral nutrition initiation during times of high or escalating doses of vasopressors until the patient is hemodynamically stable. And they do not define what a high dose of vasopressors is. They go on to say starting enteral nutrition at a low rate and advancing gradually during times of low to moderate dose vasopressors. You can do that, but while monitoring for intolerance. And of course, they don't say what low to moderate dose vasopressors are. So the goal of this analysis was to evaluate the tolerance of enteral nutrition during periods of different vasopressor and lactate levels. So we looked at the vasopressor requirements at the time of initiation, along with the lactate levels at the time of initiation, and then we looked for 24 hours after that how they tolerated the tube feeding. This was a retrospective evaluation on all the burn patients admitted to our burn center in 2018 who received enteral nutrition. This was a performance improvement project. It was approved by our regulatory compliance division. We collected lactate levels and vasopressor use just prior to enteral nutrition initiation, the highest enteral nutrition rates and gastric residual volumes during the first 24 hours after initiation, as well as any cases of ischemic bowel or aspiration after enteral nutrition initiation. We performed statistics using JUMP with significance established at p-value less than 0.05. We found means and standard deviations, or medians and interquartile ranges, and we performed linear regression and Mann-Whitney U tests. We ended up with 58 patients in this analysis with an average age of 47, average burn size of 29%, median ventilator days of 13, and a 15% mortality. The enteral nutrition was initiated a median of 25 hours after admission. The maximum enteral nutrition rate achieved during the first 24 hours after initiation was an average of 100 an hour. This makes sense because we do start at 20 an hour and we ramp up by 20 every 4 hours. The lactate level at the time of initiation was a median of 1.9. Here we performed linear regression on the lactate level at the time of initiation, along with the residual, the gastric residual, the highest one in the 24 hours following initiation. And you can see that there was not a significant relationship. The p-value was 0.53. Here we separated out the patients into who was getting vasopressors and who was not. The majority, 59%, did not receive any. 21% received vasopressin only, 2%, one patient, received norepinephrine only, and 19% received vasopressin and norepinephrine. Here we just separated the patients out by if they received pressors or not, yes or no. And we looked at their residual levels. So those who were receiving pressors at the time of initiation of the enteral nutrition did have significantly higher gastric residual volumes with a P of 0.014. However, you could see that the levels were not necessarily clinically significant. So you could see the median was about 14 for no pressors and about 200 for those who had pressors. When we separated it out into if you had a residual over 500, it was not significant. Here we looked at, with linear regression, at two different ways of analyzing the pressors. So the first group, we just looked at the ones who received only vasopressin. And they received an average of 0.03 units per minute. The p-value was actually significant at 0.047 when looking at the gastric residuals and the dose of vasopressin. However, you can see it's a weak relationship with the R-squared of 0.339. Now, we looked at all the patients who received norepinephrine, and they received an average of 3.3 mics per minute, and there was not a statistically significant association. All right, the clinical results. This is the most interesting part. There was one case of aspiration, and there was one case of ischemic bowel. Both occurred 3 days after enteral nutrition initiation. Both received no vasopressors, and both had normal lactate levels at the time of initiation. So we found no indication for holding nutrition in critically ill burn patients with these vasopressor requirements or lactate levels. However, of course, further investigation is warranted before recommendations can be made. Thank you.